Joseph Harris, May 5th, 2021. Okay, for the first Unit 4 case script, I'm going to start with Case 1. In Case 1, we've got a newborn who appears normal at birth, but within 24 hours develops lethargy, hypothermia, and apnea. The attending physician suspects metabolic disorder, orders panels of labs. Blood work comes back, ammonia levels are high, citrulline levels are normal, and orotic acid levels are high. First, I'm going to discuss nitrogen transport and the movement in the body. The movement of nitrogen starts with a series of transaminations followed by oxidative deaminations and then to the urea cycle. Transaminations are facilitated by aminotransferases enzymes with the cofactor pyridoxal phosphate. In addition to aminotransferases, there are 3 additional enzymes that play essential roles in nitrogen transport. First, glutamine synthetase, which reacts with glutamate to affix free ammonia to make glutamine, which is one of our primary non-toxic nitrogen carriers. Second, in the liver, the reaction with glutaminase will free an ammonium that will enter the urea cycle. Third, the remaining glutamate will enter a reaction with glutamate dehydrogenase to free the remaining ammonium that will enter the urea cycle. During the alanine glucose cycle occurring in the skeletal muscles, transamination takes place in order to shuttle alanine to the liver to transaminate to pyruvate and glutamate. Pyruvate can be used in gluconeogenesis in the fasted state to produce glucose. So back to the patient, when looking at the blood work, orotic acid levels are elevated, suggesting an accumulation of carboxyl phosphate. Blood ammonia levels are high, and the intermediate citrulline is normal. Given these lab findings, carboxyl phosphate synthase 1 is active and producing carboxyl phosphate, making it the least likely deficient enzyme. The buildup of carboxyl phosphate suggests ornithine carboxyl transferase is most likely the deficient enzyme, leading to the elevated ammonia in circulation. Arginine levels would expect to be low as well, making it an essential amino acid for in regulation of urea. So in case 2, we've got 3 scenarios. So let's start with scenario 1. A full-term girl was born by normal vaginal delivery and was released from the hospital at 3 days of age. At 9 days of age, a screening test for branched-chain amino acids came back positive, and the child was readmitted to the hospital for further evaluation. There was no history of any genetic disease in either family, and both older siblings were well. So in this scenario, the most likely enzyme deficiency is branched-chain keto acid decarbylase, resulting in the branch-chain amino acid leucine, valine, and isoleucine not being metabolized in what is called maple syrup urine disease. That would probably make these essential amino acids, and the cofactor thiamine is needed in the metabolism of branched-chain amino acids during oxidative decarboxylation. In scenario 2, a 69-year-old woman presented with a 30-year history of lower back and large joint pain in the hips and shoulders. On examination, blue-grade pigmented macules were present over the cartilaginous portions of the ears and the sclera. Past medical history included aortic stenosis. So in scenario 2, the most likely enzyme deficiency is homogenistic acid oxidase, resulting in accumulation of homogenistic acid in connective tissue, which is called alkaptonuria. I don't believe there's an amino acid becoming essential in this deficiency. I did not come across that. I did read that high doses of vitamin C can be used to treat alkaptonuria, and it hinders the accumulation and deposition of homogenistic acid. However, long-term use is proven ineffective. In scenario 3, a 4-day-old infant is being followed in your clinic. Her birth weight is 5.9 pounds, and the pregnancy and birth were normal. Results from normal screening demonstrated phenylalanine levels of 6.6, which is high. So in scenario 3, here, the most likely enzyme deficiency is phenylalanine dehydrogenase and possibly the cofactor tetrahydrobiopterin, which is BH4. This leads to a decreased production of tyrosine in a condition known as phenylketonuria, PKU. Tyrosine will become conditionally essential and must be supplied from an exogenous source. Many vitamin supplements are needed with phenylalanine-free diet, including L-tyrosine to help supply missing tyrosine, and vitamin K, vitamin B12, and selenium to make up for the low-protein diet. And then my citations I've got here, and I believe that is everything for the cases. Thank you.